speaker is Dr. Ammar Chaudhary. He's a consultant cardiologist at Department of Cardiovascular Disease, King Faisal Specialist Hospital and Jeddah. He will talk about chronic heart management in the light of guidelines. Please.
Thank you very much, and I want to thank the organizers, Dr. Tabalat and Dr. Badr, for having me here. So we heard an excellent introduction by Dr. Bimraj about the diagnostic workup for heart failure, and I'm going to discuss the management of chronic heart failure in view of the guideline recommendations. This is a fairly expansive discussion, so it's going to be mostly an overview, and we'll have speakers later in the day expand on these specific areas. Now, as you heard, heart failure is divided into HFpEF and HFrEF, broadly speaking, and we can talk about, HFpEF, particularly if we're interested to talk about negative trials. So that's a separate ball game, and unfortunately, we don't have a lot of evidence for HFpEF. And talking about negative trials is important because we learn a lot from them. There are ongoing studies to figure out how we can improve outcomes for the HFpEF population. But what I'm going to focus mostly on is HFrEF because it has a large body of evidence. There are lots of interventions as outlined here. So to your left basically are interventions that have a proven track record of reducing mortality, and they receive a high level of recommendation in the guidelines, with the exception of SGLT2 inhibitors because the guidelines haven't caught up with the evidence yet. But the panel in the middle and on the right are interventions that are important. They, at a minimum, reduce morbidity and in some instances reduce mortality, although the evidence base for mortality reduction may not be as robust. So they receive a varying level of recommendation depending on which society you're looking at. But they should be given strong consideration when you're managing your patients. Now, this large body of evidence did not develop overnight. It was a culmination of research work that started more than 30 years ago. And what is notable is that therapies for vasodilatation that exploit the vasodilation theory or this pathway were the first to be started back in 1986, and up until last year, there were trials that were still ongoing in regards to this pathway. And we'll start with some of these clinical trials and see what the guidelines have to say about them. So the combination of hydralazine nitrate was the first to be tested back in 1986 in the VHEFT-1 study. The trial was powered for all-cause mortality, and investigators had to use 3 different statistical models, and the lowest p-value they were able to get was 0.05. So all-cause mortality reduction was achieved, but the statistical significance of this finding was borderline. So we use these agents. It's important to consider them, in patients where we cannot use renin-angiotensin aldosterone inhibitors in 2 situations where patients have prohibitive hyperkalemia or prohibitive renal failure. So it receives, for that reason, a Class 2A recommendation in the ACC guidelines for this particular reason, a 2B recommendation in the European guidelines, and with the exception of using them in the African American cohort of patients where adding them on to background therapy that included RAAS inhibition in advanced heart failure symptoms, NYHA 3 and 4 led to significant reduction in mortality. So that's the only situation where it receives a Class 1 recommendation. Now, with regards to ACE inhibitors, these are considered the cornerstone of heart failure across all guidelines, and that's a recommendation based on a body of evidence that's summarized in these 2 trials. So to your left is a consensus trial where NYHA 4 patients benefited significantly with enalapril very early on in terms of all-cause mortality. And when investigators sought to generalize these findings in NYHA 2 and 3 patients, which are the vast majority of heart failure patients in the SOLVE treatment trial, it took much longer to demonstrate a statistically significant but clinically relatively modest reduction of 16% in all-cause mortality, modest in comparison to consensus, of course. So this is why ACE inhibitors receive a class 1 recommendation. With regards to ARBs, valsartan and candesartan, the secondary endpoint reduction of cardiovascular mortality was not achieved. The composite endpoint was statistically significant. And this theme continues even if you look at a subset of populations outside of heart failure. There is a persistent signal for an advantage with ACE inhibitors that is not seen with ARBs. And that's why ACE inhibitors receive a class 1. ARBs also receive a class 1, but only as an alternative to ACE inhibitors if they cannot be tolerated due to angioedema or cough. And so one theory is that ACE inhibitors increase bradykinin, which is an endogenous vasodilator. So maybe that's the reason why ACE inhibitors are more beneficial. Now, some practical points here. This is a class effect. You can use whichever ACE inhibitor you want. You need to aim for the target doses in the clinical trials, but intermediate doses are likely as beneficial as high doses. They're preferred once the patient recovers from the acute decompensated heart failure, also in the volume overloaded patient. You need to up-titrate every 2 weeks and make sure that you monitor the electrolytes and renal profile as well. Exercise caution when blood pressure is low or GFR is less than 30, but their use is not prohibited. And you may use a short-acting drug like captopril if you have concerns. So investigators, again, sought to continue to exploit the endogenous vasodilatory peptides. And there was a lot of work being done back then with the discovery of neprilysin and what its inhibition can do. But this journey was punctuated by other important trials. So in the late 90s and early 2000s, beta blocker trials emerged, and they're summarized here. There were a study with bisoprolol, another one with metoprolol succinate, and a third one with carvedilol. And they all shared the same theme in that the trials were terminated early because of overwhelming benefit that was seen within 3 months to 6 months in terms of all-cause mortality reduction that approached 35%. So this was class leading in comparison to any other class of drugs, and it established the role of beta blockers as a cornerstone in heart failure management. Now, this is not a class effect because the same benefit is not seen with other types of beta blockers. When you're titrating every 2 weeks as tolerated, you want to make sure that you achieve the doses that were used in the clinical trials, and dosing over here is even more important than dosing with ACE inhibitors. But these are usually the therapies that are the most difficult to start, and we start them once they're offloaded, once they're euvolemic, and you need to monitor for congestion. And if there are concerns, the patient recently came off inotropes and their blood pressure is soft, you may use a short-acting beta blocker in the beginning at very low doses. But if you're struggling with blood pressure and the patient is on low doses of ACE and beta blockers, the guidelines recommend giving preference to beta blockers because of their overwhelming benefit. Clinical trials of mineralocorticoid receptor antagonists are summarized here, and 2 of them are presented in this slide. So again, on your left side is a RAAS trial. Patients with NYHA 3 and 4 with reduced EF were enrolled, but this was in the late 90s where very few patients were receiving beta blockers. So there was a significant mortality reduction in the order of 30% relative. Investigators sought to study these agents in a more contemporary setting where patients were receiving beta blockers in NYHA functional class 2, which are the vast majority of our heart failure patients. And again, in EMPhASIS trial, there was a 24% reduction in all-cause mortality. So you talked about the endogenous compensatory peptides that counteract the RAAS system, and they include bradykinin, the natriuretic peptides. And neprilysin is an enzyme that breaks them down, so they're all substrates for neprilysin, including angiotensin. And the theory is that if you inhibit neprilysin alone, you will not get a clinical benefit because you're increasing angiotensin levels as well. But if you combine it with an ARB or an ACE, you tip the balance in favor of the endogenous peptides, the vasodilatory peptides. Combining it with an ACE is dangerous because that could lead to excessive vasodilation and angioedema. So this is how the class angiotensin receptor neprilysin inhibitor was developed. We call them ARNI, sacubitril/valsartan, and the commercial name is Entresto. So this was the subject of the largest clinical trial, pivotal trial in heart failure paradigm, where the comparator was enalapril. It's the gold standard ACE inhibitor, and the dose that was used in SALT treatment was used in this trial. And by design, they ended up including NYHA2 and NYHA3 patients, so NYHA1 and 4 were not represented. These were stable chronic heart failure patients that were not in the hospital. They were on background beta blocker therapy and an ACE inhibitor, and there were some cutoffs in terms of blood pressure and GFR. And we know the rest of the story in terms of the primary composite endpoint reduction, which was very significant with lots of zeros in the p-value, but also an all-cause mortality reduction of 16% in comparison to enalapril. And if you remember, enalapril to compare to placebo was also 16%. So that puts this class of drugs in the beta blocker territory in terms of its benefit. The interpretation of the societies and the guidelines is generally the same with small caveats. So the American guidelines restrict the use of ARNI to NYHA2 and 3. You don't have to have them on an MRA before switching them to an ARNI, but the European and the Canadian guidelines mandate the use of all 3 classes of drugs, ACEs, beta blocker, and MRA before doing the switch, and they don't specifically leave out NYHA4 from the recommendation. Another important signal in the paradigm was a reduction in heart failure hospitalization, which is a major concern with heart failure patients, and there's a lot of effort to see how we can reduce this particular endpoint. And this was seen in these stable, quote-unquote stable chronic heart failure patient. The investigators sought to look at whether earlier use and earlier introduction of ARNI during hospitalization, once the patient recovers from their acute decompensation, would be superior one way or the other in comparison to the standard of using ACE inhibitors. So this was subject of a clinical trial called Pioneer, and these were the inclusion criteria that were used, and if you want to apply them to your practice, that would be advisable. So systolic blood pressure had to be more than 100. There was no dose escalation of diuretics. They were off IV vasodilators and inotropes, and an uptitration algorithm was used based on blood pressure. And this trial was small, and it was a short follow-up of 8 weeks, so it was powered not for clinical endpoints, but for biomarker endpoints. So they were looking at basically NT-proBNP reduction in the 2 arms, and the reduction was more significant in the Entresto arm in comparison to enalapril, and this was seen early on within the first week of the randomization, and it persisted over the duration of the trial, which was 8 weeks. So 30% reduction in NT-proBNP, which is a marker of future events. Now, why the trial was not, the follow-up period was short, it wasn't more prolonged, because then the patients transitioned to a chronic heart failure state, and it would not be ethically appropriate to keep them on an inferior drug like enalapril. However, a composite endpoint, a clinical endpoint that included heart failure hospitalization mortality, this was exploratory, and there was a reduction in the order of 46%, mostly driven by reduction in heart failure hospitalization. So a couple of key points: use ARNIs if the patient is symptomatic despite optimal medical therapy. You can debate whether you should have them on all 3 classes at the maximum doses or do an earlier switch because of the overwhelming benefits. You need to make sure that once you're doing the switch, you observe the 36-hour washout period. In patients with borderline blood pressure, you may eliminate unnecessary medications, and you may use them in the acute decompensated patient once they are out of the acute decompensation prior to discharge. And this receives a 2A recommendation in the recent consensus guidelines for the hospitalized heart failure patient by the ACC and the ESC. They were published in 2019. Low-dose Entresto 50 BID can be considered if the patient is ACE or ARB naive, and certainly these patients were included in 2 trials, Transition and Pioneer. So if you're sticking to the inclusion criteria of the trial, that is reasonable to do, and you can still use them if the GFR is less than 30. All right, now we move on to other interventions that don't receive a class 1 recommendation, but they're still recommended in the guidelines. So ivabradine reduces heart rate. It targets the SA node specifically, and this was subject of a large clinical trial, the SHIFT trial. Patients were included if their EF was less than 35%, NYHA 2 and 3. Heart rate was reduced by an average of 8 beats per minute, and the composite of cardiovascular mortality and hospitalization was reduced mostly because of heart failure hospitalization in the order of 26%. So this receives a 2A recommendation in the ACC and the ESC guidelines. The starting dose depends on the age, depends on the heart rate. If their heart rate is less than 50, you may discontinue or reduce the dose. 50 to 60 heart rate, keep them at the same dose, and if it's more than 60, you may escalate it to a target of 7.5 twice a day. Digoxin now has been downgraded to a 2A in the ACC guidelines and 2B in the European guidelines. There are toxicity issues. Mortality reduction was not convincingly shown. Routine anticoagulation in sinus rhythm is still a class 3. With regards to IV iron, this was subject of 2 trials, modest size, FAIR-HF and CONFIRM, and they were designed and executed by the same European group, so the inclusion criteria were pretty much identical. These were patients with an EF less than 45, NYHA 2 and 3. Regardless of their hemoglobin, up to a hemoglobin of 14 were allowed to be enrolled as long as they met the serologic definition for iron deficiency, a ferritin of less than 100 or a ferritin of between 100 and 300 if they have a transferrin saturation of less than 20%. And they're powered for quality of life measures and objective assessment of functional capacity. And in the CONFIRM trial, there was an improvement. So there was an improvement in the walk distance in the treatment arm, while it was less and less in the placebo arm. An exploratory endpoint for hospitalization was also reduced. So this receives a 2A recommendation in the European guidelines, a strong recommendation in the Canadian guidelines, and a 2B recommendation in the American guidelines because they were not powered for hard clinical endpoints. But clinical trials are ongoing. On your right side are a couple of studies that are powered for all-cause mortality. There are also studies looking at HFpEF and the acute decompensated heart failure population. Not going to spend much time on devices. Suffice it to say that symptomatic patients with EF less than 35% and non-ischemic should receive an ICD if they're on guideline-directed medical therapy. For the ischemic, they don't have to be symptomatic. EF less than 35% should receive it. CRT has similar indications, and the QRS width obviously has to be taken into consideration. So a couple of other very important interventions that may not have a lot of body of evidence, but we use them routinely. They're very important. Diuretic therapy has a class 1 recommendation, obviously. Ultrafiltration can be used if diuretic therapy, aggressive diuretic therapy is not working. You need to ask your patients to restrict their fluid intake to less than 2 liters a day. Maybe tighter fluid restriction for those with more advanced symptoms. Blood pressure target less than 130/80. Etiology-based, so we didn't talk about disease-specific recommendations. That's a very expansive topic, but I'll just mention here that the idea of revascularization in ischemic cardiomyopathy when EF is less than 35% for mortality gain is somewhat a controversial topic. It receives a weak recommendation in the American guidelines from 2013, although the STITCH trial on which the basis, this is a trial that provided the basis for this recommendation, initially did not show an all-cause mortality reduction, but the 10-year follow-up results did show a mortality reduction. So maybe in the next update of the guidelines, there might be a consideration of this recommendation level to a higher level. Follow-up in disease management program is important. Follow-up post-discharge within 7 to 14 days should also be considered. All right, so I'm just going to wrap up quickly with a couple of interventions that are not yet mentioned in the guidelines, but they might receive some recommendation or some endorsement once they are updated in the near future. SGLT2 inhibitors have been shown in a sort of a prevention setting, diabetic patients, to reduce their incidence of heart failure and mortality. So now they're the subject of trials in patients with established heart failure. And DAPA-HF that was published a couple of months ago looked at this in both diabetics and non-diabetic patients with established heart failure based on inclusion criteria that are very, very similar to the Paradigm trial, that there was a significant reduction in all-cause mortality in the order of 17%, cardiovascular mortality in the order of 18%. The Emperor trial with empagliflozin, DAPA-HF was dapagliflozin, Emperor is empagliflozin. This is an ongoing study that will be completed this year. AFib ablation, a small study called Castle AF received a lot of attention, although there are some issues with the study in terms of the the size of the trial, the follow-up, the loss to follow up, the unequal distribution of the underlying disease etiology. So there were more ischemic patients in the medical therapy arm, for example. It was non-blinded. There was no sham intervention, but in any case, the study did show a significant reduction in the composite of death and hospitalization. You'll be hearing probably more about MitraClip in the functional MR population. The COAP trial did show significant reductions in hospitalization and all-cause mortality. This is only one study. The other study in France did not show the same benefit. So it's important to, if you're considering this intervention, to adhere to the inclusion criteria of the COAP trial in terms of ejection fractions and LV volumes and assessment of mitral regurgitation. So remote monitoring has been a hot area as well. And the idea is that you monitor your patients when they are home and escalate their therapies and preempt their decompensation. And the current trend is to use implantable devices like cardiomems in the pulmonary artery that can send data remotely and to give you information about their filling pressures. Surrogate, basically, it measures pulmonary artery pressures. And it's been shown in one trial to reduce the risk of hospitalization significantly. So I'll wrap up this topic with some conclusions. The key message here is that adherence to guideline-directed medical therapy is crucial to achieving desired outcomes, and that attempts at GDMT should be exhausted before considering advanced therapies. If we talk about LVAD or heart transplant, don't rush to that until you're sure that your patient has exhausted all options that we mentioned. GDMT is resource intensive, and funding for therapies and programs is justified to offset the high burden of cost with heart failure. I'll stop here. Thank you very much.
Thank you, Dr. Ammar, for this elegant talk. We are running short of time, so we leave questions for the coffee break. Thank you. And my microphone to Dr. Ahmed. Please, Dr. Ahmed.
One question.
Do you use nebivolol for heart failure? You mentioned the major 3 beta blockers, but what about the role of nebivolol?
Yeah, I mean, it doesn't receive a guideline recommendation per se, largely because of the evidence base is not really as solid for nebivolol. It has some more theoretical advantages in being super selective, and patients with reactive airway disease, it may be an option. But other than that, really, we tend to use the 3 agents that I mentioned.
Thank you very much, and we will have more time for discussions along the day.